Hello everybody. Today we have a lecture about the adrenal incidentaloma.
Doctor, what is the adrenal incidentaloma?
An adrenal incidentaloma is a mass lesion greater than 1 centimeter in diameter, serendipitously discovered by radiologic examination. This entity is the result of technological advances in imaging such as computed tomography, CORT, and magnetic resonance imaging, MRI. Discovery of an adrenal mass raises two questions that determine the degree of evaluation and the need for therapy. Is it malignant? Is it functioning?
Doctor, what is the prevalence of the adrenal incidentaloma?
Adrenal masses may be found incidentally when CT scans or MRIs are done for other reasons. In a study of 61,054 abdominal CT scans performed from 1985 to 1990, an incidental adrenal tumor, incidentaloma greater than 1 centimeter, was detected in 259 patients, 0.4% of all CT scans. A subsequent study, utilizing higher resolution scanners, reported a prevalence of adrenal incidentaloma on abdominal CT of 4.4%. The prevalence of adrenal incidentaloma is higher in older patients, 10%. In autopsy studies, the prevalence of incidentalomas is 2%, and it ranges from 1 to 9%. The prevalence is higher in obese, diabetic, and hypertensive patients. As an example, in a series of 739 autopsies, adrenal masses between 2 mm and 4 cm in size were present in 9% of normotensive patients, and in 12% of patients who had hypertension.
Doctor, can it be bilateral?
Analyses from two large adrenal incidentaloma studies with 887 and 202 patients showed that bilateral masses were found in 10 to 15% of cases. Bilateral adrenal masses can be seen with metastatic disease, congenital adrenal hyperplasia, cortical adenomas, lymphoma, infection, for example, tuberculosis, fungal, hemorrhage, ACE-dependent Cushing's, pyochromocythoma, amyloidosis, infiltrative disease of the adrenal glands, and ACE-independent bilateral macronodular adrenal hyperplasia. In one study of 208 adrenal incidentaloma patients, 9% proved to have adrenal metastases. 10 of the 19 patients, 53%, had bilateral disease. In some patients with bilateral disease, one adrenal mass proves to be a non-functioning cortical adenoma, while the contralateral adrenal mass is hormone-secreting. In addition, adrenocortical hyperfunction may occur in patients with bilateral adrenal masses. Therefore, all patients with bilateral adrenal masses should be screened for adrenocortical hyper and hypofunction.
Doctor, what about evaluation for malignancy?
Malignancy is an uncommon cause of adrenal incidentaloma in patients without a known diagnosis of cancer. Although estimates have varied widely, the actual frequency of primary adrenal carcinoma in patients with adrenal incidentaloma is approximately 2 to 5%. Another 0.7 to 2.5% have non-adrenal metastasis to the adrenal gland. The size and imaging characteristics, imaging phenotype of the mass may help determine whether the tumor is benign or malignant. Regarding the size of the mass, the maximum diameter of the adrenal mass is predictive of malignancy. This was illustrated in a study of 887 patients with adrenal incidentalomas from the National Italian Study Group on Adrenal Tumors. Adrenocortical carcinomas were significantly associated with mass size, with 90% being more than 4 centimeters in diameter when discovered. Adrenal mass size is also important because the smaller the adrenocortical carcinoma is at the time of diagnosis, the better the overall prognosis. In a retrospective review of 62 patients with adrenocortical carcinoma, 5-year survival was approximately 16% overall, but much higher, 42%, in patients with smaller tumors, stages A and II, confined to the adrenal gland, who were more likely to undergo curative resection. In a report from the National Italian Study Group, a 4 cm cutoff had a 93% sensitivity of detecting adrenocortical carcinoma, even though specificity was limited. 76% of masses larger than 4 centimeters in diameter were benign. In the Mayo Clinic study cited above, all 20 adrenal carcinomas were between 4 and 6 centimeters in diameter. Therefore, surgical removal of unilateral adrenal masses larger than 4 centimeters should be considered to avoid missing adrenal carcinomas, particularly in younger patients. However, adrenal mass size should not be used as the only parameter to guide treatment. In particular, radiographic characteristics, imaging phenotype, and change in size over time also have strong predictive value.
Doctor, what about imaging phenotype?
CORT or MRI with 2 to 3 mm cuts may allow prediction of the histologic type of the adrenal tumor, which is particularly important in the evaluation of masses that do not meet the size criterion for removal. As an example, the lipid-rich nature of a cortical adenoma is helpful in distinguishing this benign tumor from carcinoma. On CORT scanning, the density of the image, black is less dense, is attributed to X-ray attenuation. The intracytoplasmic fat in adenomas results in low attenuation on non-enhanced CORT. Non-adenomas have higher attenuation in non-enhanced CORT. The Hounsfield scale is a semi-quantitative method of measuring X-ray attenuation. Typical pre-contrast Hounsfield unit, Q, values are adipose tissue equals -20 to -150 Q, and kidney equals 20 to 150 Q. If an adrenal mass measures less than 10 Q on unenhanced CORT, that is, has the density of fat, the likelihood that it is a benign adenoma is nearly 100%. However, up to 30% of adenomas do not contain large amounts of lipid and may be indistinguishable from non-adenomas on non-enhanced CORT scans. Regarding MRI, although CORT is the recommended primary adrenal imaging procedure in most cases, MRI has advantages in certain clinical situations. Conventional spin echo MRI is the most frequently used technique. Using low or mid-field strength magnets, T1 and T2 weighted imaging can distinguish benign adenomas from malignancy and piochromocythoma. On gadolinium enhanced MRI, adenomas demonstrate mild enhancement and a rapid washout of contrast, while malignant lesions show rapid and marked enhancement and a slower washout pattern. Chemical shift imaging MRI is a form of lipid-sensitive imaging based upon the principle that the hydrogen protons in water and lipid molecules resonate at different frequencies, referred to as chemical shift. Benign adrenal cortical adenomas lose signal on out-of-phase images, but appear relatively bright on in-phase images. Positron emission tomography, PET, with either 18-fluoro-2-deoxydeglucose, FEG, or 11-C-methomidate, MTO, can be helpful in selected patients, like those with a prior history of malignancy, or those in which CORT densitometry or washout analysis is inconclusive or suspicious for malignancy. Because of their high sensitivity for detecting malignancy.
What are the imaging characteristics of adrenal masses?
For benign adenoma, round and homogeneous density, Smooth contour and sharp margination. Diameter less than 4 cm. Unilateral location. Low unenhanced CT attenuation values, less than 10 hue. Rapid contrast medium washout, 10 minutes after administration of contrast, an absolute contrast medium washout of more than 50%. ISO intensity with liver on both T1 and T2 weighted MRI sequences chemical shift evidence of lipid on MRI.
For pheochromocytomas. Increased attenuation on non-enhanced cord, greater than 20 hue. Increased mass vascularity. Delay in contrast medium washout, 10 minutes after administration of contrast, an absolute contrast medium washout of less than 50%. High signal intensity on T2 weighted MRI cystic and hemorrhagic changes. Variable size and may be bilateral.
For adrenal metastases. Irregular shape and inhomogeneous nature. Tendency to be bilateral. High unenhanced CT attenuation values, greater than 20 hue, and enhancement with intravenous contrast on CT. Delay in contrast medium washout, 10 minutes after administration of contrast, an absolute contrast medium washout of less than 50%. ISO intensity or slightly less intense than the liver on T1 weighted MRI and high to intermediate signal intensity on T2 weighted MRI, representing an increased water content. Elevated standardized uptake value on 18-fluorodeoxyglucose (FEG), positron emission tomography, PET scan. Regarding others, adrenal cysts, adrenal hemorrhage, and myelodipoma are usually easily characterized because of their distinctive imaging characteristics. Despite these radiographic characteristics, currently available imaging studies can be misleading. One study, as an example, evaluated 25 patients with potentially operable non-small cell lung cancer and a unilateral adrenal mass. Thin section MRI correctly predicted a malignant tumor in all 4 patients with histologically proven metastases, but 14 of 21 histologically benign masses were read as malignant and 2 as indeterminate.
Doctor. What about fine needle aspiration biopsy?
Pathology from a specimen obtained by fine needle aspiration (FN) biopsy cannot distinguish a benign adrenal mass from the less common adrenal carcinoma. It can, however, distinguish between an adrenal tumor and a metastatic tumor. In a patient with unknown primary malignancy elsewhere who has a newly discovered adrenal mass that has an imaging phenotype consistent with metastatic disease, performing a diagnostic CT-guided FN biopsy may be indicated, but only after excluding pheochromocytoma with biochemical testing. Adrenal biopsy would not be needed if the patient was already known to have widespread metastatic disease. One report, as an example, evaluated patients with known lung cancer and an adrenal mass. FN biopsy revealed a benign adrenal lesion in 2/3 of cases. When the non-adrenal cancer is occult, most adrenal masses are incidentaloma cortical adenomas, 91 of 95 in one study. Thus, FN biopsy is not useful in a routine evaluation of incidentalomas in patients suspected to have small non-adrenal cancers. Image-guided fine needle aspiration biopsy is relatively safe. The complication rate was 2.8% in one series of 277 biopsies. The risks of this procedure include adrenal hematoma, abdominal pain, hematuria, pancreatitis, pneumothorax, formation of an adrenal abscess, and tumor recurrence along the needle track. The fine needle aspiration biopsy of a pheochromocytoma may result in hemorrhage and hypertensive crisis. Therefore, the possibility of pheochromocytoma should always be ruled out by biochemical testing before fine needle aspiration biopsy is undertaken.
Doctor. What about evaluation for hormonal secretion?
While most adrenal incidentalomas are non-functional, 10 to 15% secrete excess amounts of hormones. The most complete analysis of this issue comes from a review of all 828 published articles on adrenal incidentalomas from 1980 to 2018. Only 20 of the 828 articles were selected as having met the strict criteria for a true adrenal incidentaloma. Of these, only 9 had adequate data on both diagnosis and follow-up. Patients who were suspected as having cancer were excluded. Among the 1,800 patients in these 9 series, these overall mean percentages of diagnoses were reported: malignant, primary adrenal carcinoma 1.9%, metastasis 0.7%, benign, non-functioning 89.7%, subclinical Cushing's syndrome 6.4%, piochromocythoma 3.1%, primary aldosteronism 0.6%.
Doctor, what is the subclinical Cushing's syndrome?
Subclinical Cushing's syndrome, like glucocorticoid secretory autonomy without clinical manifestations of Cushing's syndrome, is the most frequent hormonal abnormality detected in patients with adrenal incidentalomas. Some adrenal incidentalomas secrete cortisol independently of ACTH, which may have clinically important consequences. In addition, cortisol secretion can be under the control of one or more aberrant hormone receptors in patients with unilateral adenomas or incidental bilateral ACTH-independent macronodular hyperplasia.
Doctor, what are the clinical manifestations? Although these patients lack many of the usual stigmata of overt Cushing's syndrome, they may have one or more of the effects of continuous ACTH-independent cortisol secretion, including hypertension, diabetes, and a high incidence of vertebral fractures. Those with subclinical Cushing's syndrome are more likely to have hypertension, dyslipidemia, impaired glucose tolerance, or type 2 diabetes mellitus, and evidence of atherosclerosis. In a 2-year longitudinal study of 103 consecutive patients with adrenal incidentaloma, the incidence of new vertebral fractures was higher in the group with subclinical Cushing's syndrome, 48%, than the adrenal incidentaloma group without subclinical Cushing's, 13%. Doctor, what about the diagnosis? In one large series of adrenal incidentalomas, hormone evaluation in the patients with subclinical Cushing's syndrome showed the following. Low baseline secretion of corticotropy ACTH in 79%, lack of suppressibility of cortisol secretion after 1 mg dexamethasone in 73%, supranormal 24-hour urinary cortisol excretion in 75%. Disturbed cortisol circadian rhythm in 43%. Blunted plasma ACTH responses, the corticotropy releasing hormone in 55%.
Because of a lack of sensitivity of most corticotropy ACTH assays at the lower part of the reference range, most centers rely on an alternate measure of autonomous cortisol secretion. The overnight dexamethasone suppression test, DST. Some centers use a higher dose of dexamethasone, like 3 mg rather than the standard 1 mg, to reduce false positive results. And others use a lower cortisol cutoff, like greater than 2.2 mg/dl, greater than 16 mol/L, or 1.8 mg/dl, 15 mol/L, rather than greater than 5 mg/dl, greater than 138 mol/L, to reduce false negative results.
Doctor, should all patients with subclinical Cushing's syndrome undergo unilateral adrenalectomy?
In the absence of a prospective randomized study, it is reasonable to consider that younger patients and those who have disorders potentially attributable to excess glucocorticoid secretion, like recent onset of hypertension, diabetes, obesity, and low bone mass, and have well-documented glucocorticoid secretory autonomy, suppressed aace, low serum ACTH concentration, lack of suppression to high-dose overnight DST, 8 serum cortisol greater than 5 mg/dl are candidates for adrenalectomy. If adrenalectomy is performed, perioperative glucocorticoid coverage should be administered because of the risk of adrenal insufficiency, hemodynamic crisis, and death. Weight loss, improvement in hypertension and/or glycemic control, and normalization of markers of bone turnover are frequently found following unilateral adrenalectomy in patients with subclinical Cushing's syndrome. Regarding piochromocythoma, approximately 3% of adrenal incidentalomas prove to be piochromocythomas. In the past, it was thought that all patients with piochromocythoma are symptomatic. However, with widespread use of computed imaging, piochromocythomas are being discovered in the presymptomatic stage. Although some recommend measurement of plasma fractionated metanephrines in all patients with adrenal incidentaloma, we suggest this measurement only when the pre-test probability of piochromocythoma is high, if the mass is vascular, dense, and has slow contrast washout, because while this test is very sensitive, 95 to 98%, it is not very specific, 89 to 95%. 12,45, 46. In patients with adrenal masses that, based on imaging phenotype, have a low probability for piochromocythoma, the adrenal mass is hyperdense with rapid contrast washout, we suggest routine measurement of 24-hour urinary fractionated metanephrines and catecholamines. Regarding aldosteronomas, aldosteronomas are rare, less than 1%, causes of an adrenal incidentaloma. However, because the majority of patients with primary aldosteronism are not hypokalemic, all patients with hypertension and an adrenal incidentaloma should be evaluated by measurements of plasma aldosterone concentration and plasma renin activity.
Doctor, what about the treatment?
Regarding unilateral adrenal masses, all patients with documented piochromocythoma and adrenocortical cancer should undergo prompt surgical intervention because untreated piochromocythoma may result in significant cardiovascular complications. Alpha blockade should be given before patients undergo adrenalectomy. Patients with adrenocortical cancer or lesions suspicious for adrenocortical cancer should also undergo prompt adrenalectomy as their disease may progress rapidly. Patients with aldosterone-producing adenomas should be offered surgery to cure aldosterone excess. Some patients with documented subclinical Cushing's syndrome should be selected for surgery based upon the clinical parameters. Adrenal masses with either suspicious imaging phenotype or size larger than 4 cm should be considered for resection, because a substantial fraction will be adrenocortical carcinomas. The clinical scenario and patient age frequently guide the management decisions in patients who have adrenal incidentalomas that fall on either side of the 4 cm diameter cutoff. As an example, most clinicians would advise resecting a uniform hyperdense 9Hu 3.7 cm adrenal incidentaloma in a 23-year-old woman, whereas most clinicians would choose serial imaging follow-up in an 83-year-old woman with a uniform hyperdense 9Hu 4.7 cm adrenal incidentaloma. Surgical resection should be considered in this example of a young woman because adrenal cortical nodularity is, in part, a function of aging, and such a finding in a 23-year-old is not normal. In addition, the alternative would be long-term imaging follow-up, which is associated with clinically significant expense, worry, and risks. Before surgery, all patients should undergo appropriate testing for functional tumors. Adrenal myelolipoma is a benign tumor composed of mature fat and interspersed hematopoietic elements that resemble bone marrow. On computed imaging, the presence of large amounts of macroscopic fat in an adrenal mass is diagnostic of a myelolipoma. Although adrenal myelolipomas may grow over time, they can usually be followed without surgical excision. However, when larger than 6 centimeters in diameter, or when causing local mass effect symptoms, surgical removal should be considered. Regarding bilateral adrenal masses, the management of bilateral adrenal masses is different from that for unilateral masses. As an example, in cases of subclinical ACTH-independent bilateral macronodular adrenal hyperplasia, size is not an indication for surgery, as some can be as large as 5 to 10 centimeters with insufficient hormone production to necessitate surgery. Patients with bilateral adrenal masses should be investigated for congenital adrenal hyperplasia. Adrenalectomy for patients with aldosteronemas, piochromocythoma, cortisol-secreting tumors, and adrenal incidentalomas is safe and effective. An adrenalectomy may be done laparoscopically, endoscopically via the posterior approach, or as an open procedure. Laparoscopic adrenalectomy, compared with open adrenalectomy, is associated with less pain, shorter hospitalization time, less blood loss, and faster recovery. The laparoscopic approach is used for most adrenal masses. In patients with known or suspected adrenal carcinoma, the laparoscopic approach should only be considered if the adrenal mass is less than 10 centimeters and does not appear to be locally invasive. An open adrenalectomy is recommended for all large, greater than 10 centimeters, adrenal masses, including those benign imaging features, as the adrenal mass may be diagnosed as malignant on a definitive histologic review.
Doctor, what about follow-up?
For incidentalomas with a benign appearance on imaging, repeat imaging after 3 to 6 months should be performed to re-evaluate for possible malignancy. The decision to obtain additional images at 6, 12, and 24 months after the initial image and the type of image obtained, CT or MRI, should be guided by the individual clinical circumstance. Imaging for phenotype and clinical judgment. As an example, a single repeat image is reasonable in patients who have no history of malignancy and who have small, less than 2 centimeters, uniform, hyperdense, cortical nodules, like benign imaging phenotype. There are no prospective studies of the optimal frequency and duration of follow-up for adrenal incidentalomas. In addition, the radiation exposure related to CT should be considered. Most experts would consider resecting any tumor that enlarges by more than 1 centimeter in diameter during the follow-up period. However, most adrenal masses that grow are not malignant. The observation that autonomous function, glucocorticoid and catecholamine not present at baseline may be detected at follow-up testing, has led to the recommendation for repeating hormonal evaluation annually for 4 years in cases where initial evaluation is negative. However, the yield and cost-effectiveness of such testing is also unknown.
Doctor, can you tell us the summary and recommendations?
Regarding evaluation, all patients with adrenal incidentalomas should be evaluated for the possibility of subclinical hormonal hyperfunction and cancer. A thorough history and physical examination are important in the initial assessment. A homogeneous adrenal mass less than 4 centimeters in diameter, with a smooth border, and an attenuation value less than 10 Hu on unenhanced CT, and rapid contrast medium washout, greater than 50% at 10 minutes, is very likely to be a benign cortical adenoma. The imaging characteristics that suggest adrenal carcinoma or metastasis include irregular shape, inhomogeneous density, high unenhanced CT attenuation values, greater than 20 Hu, delayed contrast medium washout, less than 50% at 10 minutes, diameter greater than 4 cm, and tumor calcification. Piochromocythoma should be excluded in all patients by measuring 24-hour urinary fractionated metanephrines and catecholamines. If the adrenal mass is vascular, or there are other features suggestive of piochromocythoma, the preferred test is plasma fractionated metanephrines. Subclinical Cushing's syndrome should be ruled out by performing the 1 mg overnight dexamethasone suppression test. To detect clinically significant glucocorticoid secretory autonomy, the post-overnight DST 8 AM serum cortisol concentration cutoff is greater than 5 mg/dl, greater than 138 mol/L. An abnormal 1 mg overnight dexamethasone suppression is consistent with a CTH-independent cortisol production, a finding that should be confirmed with 24-hour urinary free cortisol, serum ACTH concentration, aace, and a high-dose dexamethasone suppression test. If the adrenal incidentaloma patient is hypertensive, a plasma aldosterone to plasma renin activity ratio and plasma potassium concentration should be obtained to screen for primary aldosteronism. Regarding treatment, we recommend surgery for all patients with biochemical documentation of piochromocythoma, grade 1B. We suggest a surgical resection for patients with subclinical Cushing's syndrome who are younger and who have disorders potentially attributable to excess glucocorticoid secretion, like recent onset of hypertension, diabetes, obesity, and low bone mass, grade 2C. We suggest a surgical resection for patients with adrenal masses greater than 4 cm in diameter, grade 2B. However, the clinical scenario, imaging characteristics, and patient age frequently guide the management decisions in patients who have adrenal incidentalomas that fall on either side of the 4 cm diameter cutoff. In a patient with unknown primary malignancy elsewhere who has a newly discovered adrenal mass that has an imaging phenotype consistent with metastatic disease, performing a diagnostic CT-guided FN biopsy may be indicated, but only after excluding piochromocythoma with biochemical testing. Adrenal biopsy would not be needed if the patient was already known to have widespread metastatic disease. We recommend excision of a tumor if the initial imaging phenotype is suspicious, grade 1B. For all adrenal masses larger than 10 cm, including those masses with benign imaging phenotypes, we recommend an open adrenalectomy rather than a laparoscopic procedure, grade 1B. Regarding follow-up, we suggest a repeat imaging study at 3 to 6 months after initial discovery, grade 1C. The rationale is that many malignant lesions will grow in this interval, leading to earlier intervention. Whether to obtain additional images at 6, 12, and 24 months after initial discovery and the type of image obtained, CT, MRI, or ultrasound, should be guided by clinical judgment and imaging phenotype. The yield and cost effectiveness of such a strategy are not known. We suggest removal of any tumor that enlarges by more than 1 cm in diameter during the follow-up period, grade 2C. We suggest that hormonal testing be repeated annually for 4 years in cases where initial evaluation is negative, although the yield and cost effectiveness of such testing is also unknown. However, autonomous function, glucocorticoid not present at baseline may be detected at follow-up testing.
Thank you Dr. Athete for this excellent lecture and nice presentation.
Thank you Doctor. Thanks for all for watching this video. Hope to see you again in more next videos and lectures. And do not forget to like, share our videos, subscribe to our YouTube channel No1doctor, and follow us in social media accounts in the description below the video. With my best wishes, Dr. Athif Ahmed.